with 1.3 and 1.5 adaptation plates. The midface has 6 main vertical buttresses. They are the 2 nasofrontal, the 2 lateral zygomatic, and the 2 pterygomaxillary buttresses. Reconstruction of the zygomatic arch determines the projections and the width of the face. Repair of the vertical facial buttresses restores vertical height and resistance to occlusal forces. The exception is the pterygomaxillary buttresses, which cannot be plated. The radiological diagnosis includes a CT in the axial, coronal, and ideally parasagittal plane, since le fort fractures may be hard to identify using axial cuts alone. The instruments needed are the plate cutters, 2 bending pliers. For 1.3 mm screws, the 1 mm drill bit with 6 mm stop, and the 1.3 screwdriver shaft with holding sleeve and handle. For 1.5 mm screws, the 1.1 mm drill bit with 6 mm stop, and the 1.5 screwdriver shaft with holding sleeve and handle. Fixation of the zygomatico-frontal suture. The procedure begins with reduction of the zygomatico-frontal fracture and the application of a 5-hole 1.3 adaptation plate. The plate is contoured with the bending pliers and is positioned so that a single screw is placed on each side of the fracture at this stage. The first hole is drilled next to the fracture line in the zygoma using a 1 mm drill. A 6 mm long 1.3 mm screw is inserted. The second hole is drilled in the first plate hole cranial to the fracture line. Another 6 mm long 1.3 mm screw is inserted. These 2 screws provide some stability and allow the zygomatic arch and orbital aperture to be reduced. The 2 additional screws are placed on either side of the plate after the other fractures have been fixed. The hole over the fracture line is not used. Fixation of the zygomatic arch. The next step is fixation of the zygomatic arch, which is essential to establish the correct anterior-posterior projection and the width of the face. A straight 5-hole 1.5 adaptation plate is used for this simple fracture. However, the zygomatic arch is often comminuted, which would require a longer plate. Due to the anatomical form of the arch, pre-bending of the plate is usually not necessary. The first hole is drilled next to the fracture line in the zygomatic portion, with a 1.1 mm drill bit with 6 mm stop. A 6 mm long 1.5 mm screw is inserted. Another screw is inserted on the opposite side of the fracture line. Traction on the plate can be used to achieve a better reduction of the zygomatic arch. Two more screws are inserted, one on each side of the fracture line. Confirmation of the correct three-dimensional reduction of the zygoma is made by an intraorbital examination of the lateral orbital wall. It's important to make sure that there's no step-off between the greater wing of the sphenoid and the zygoma. During reduction of the zygoma, the alignment of the lateral orbital wall should be reconfirmed. If the alignment is correct, the 2 remaining screws are now placed in the first plate. The fixation of the zygomatic complex is repeated on the opposite side of the face, with a 1.3 plate placed at the zygomatico-frontal fracture and a 1.5 plate on the zygomatic arch. Plating of the nasofrontal and the inferior orbital rim fracture. Plating of the right orbital aperture will be completed with reduction of the medial maxillary nasal segment. The nasal frontal and the inferior orbital rim fracture plating is done with 1.3 plates. A minimum of 2 screws are inserted on each side of the fractures. In case of an orbital wall defect, reconstruction could be necessary. This model can be used for an orbital floor mesh plate, also known as a fan plate, to repair a left medial orbital floor fracture. The defect has been marked on the model. The cutter for strut and mesh plates is needed. The radial design of the plate fits the conical shape of the orbit and can be cut to size. The orbital floor mesh plate is designed to allow fixation to the orbital rim. If an orbital rim plate has already been placed, the mesh plate can be cut accordingly. All sharp edges are trimmed, and soft tissues are properly retracted to ensure that they are not trapped. It is important to use a large enough plate to span the edges of the orbit, with particular care taken to span the posterior ledge of the orbit. After the posterior ledge is spanned, the orbital mesh plate requires only minimal screw placement.